Mental health patients have to be taught to check in with the nurse therapist, or with someone in the mental health community that can do something for them, whether it be the nurse, whether it be the therapist, whether it be someone in their group, their therapy group, something, to get them in contact with somebody when there might be possible med changes or when they need crisis counseling, when things are particularly stressful in their lives. They have to have someone that is that go-to person that can either get them to someone that can help them or can direct them, because if they're in that crisis mode, they may not be able to think clearly, and they may not be able to remember what is the appropriate response for them to do to get to where they need to be. So check-in is very important. Stress is taught to be a challenge rather than something to be feared, and that is key for them also. They have to understand that it's not a fear. They don't need to fear that there's a stress that's in their life, but it's a challenge. It's something that they have to deal with to get to the next phase, to get to something good. That stress is just going to be there. They cannot completely eliminate all of the stress in their lives. Okay, we're going to move on to signs and symptoms. Mental health patients need to understand and know what the signs and symptoms are that are characteristic to their illness, and the particular meaning that those signs and symptoms have for that patient. They need to understand that every patient has a unique pattern of symptoms. Somebody that is bipolar may be the one that talks all the time because they tend to have more manic phases than depressive phases. Somebody else that is bipolar might be the one that cries all the time because they have more depressive um, symptoms than they do manic symptoms. So the patients themselves and their families have to understand that just because they have the same diagnosis as someone else that they know or have heard about doesn't mean that they're going to have the exact same symptoms that the other person does, that they are unique to each person. Um, Mental health patients and their families also need to be taught that the symptoms are not negative, but rather they're indicators for dealing with the illness. Um, Patients have to be identified and figure out what their individual symptom patterns are from interviews with the patients themselves, with the families, and then when you as the healthcare professional figures out what those patterns are, you tell them. You sit down with them and have discussions about them, after the interviews, and let them know what that pattern is, so that they're all aware of it. And when something changes, then everyone is aware of those changes and knows that that's a red flag for someone to start doing something. Um, for example, if there's a loss of energy as a sign and symptom of recurrent depression for someone, then the family will become concerned if that person becomes inactive at night, falls asleep, loses interest in outside activities, or something like that. So when they learn what those symptomatic patterns are for them that are particular to just them, then everyone can be aware of them, and like I said, they become that red flag to know that something needs to be done differently for this person, that they could potentially go into a crisis mode, or that everybody needs to be aware of it to get them to therapy, to get them to counseling, to get those meds changed, whatever it needs to be done for them to get them out of this mode. The most important related to changes in signs and symptoms is immediate initiation of psychotherapy, med therapy, or both to avoid that relapse. That's why it's so critical for everyone to be aware of these signs and symptoms that are specific to that particular patient to prevent that relapse. You want to know what happens what that thing is that it knows that they're about to be in crisis mode, so that you can avoid crisis mode and avoid that relapse at that time. Resocialization is the next thing that we need to talk about. One of the most critical problems that mental health patients have are explaining hospitalizations to coworkers and acquaintances. They have to be encouraged before they're ever even discharged from the hospital, and how to formulate answers while they're in therapy, so that they know what to expect, and they know what they're going to say when the situation occurs. Don't let them get back out into the world, back into the social setting, and be faced with this and not have a clue as to have even expected it or no clue as to what they should say, either one. The therapist plays the role of the employer or the friend, and then the patient plays out how they would act, or they should act. And it's a role playing situation that gives them some connection with what's going to happen when they re socialize back into the real world. Most often, it's done repeatedly until the patient establishes behavioral and verbal responses that are most effective for them. So, again, this starts before the patient ever even leaves the inpatient setting so that they are adequately prepared to deal with this once they get back into the real world, so to speak. Many patients often delay rejoining groups and activities for this reason, and there's a fine line between joining too soon and delaying so long that they become phobic about it. If they can confidently explain their absence, they will rejoin those activities sooner. So this is something that needs to be done for them before they ever leave, so that they are confident, and so that they do get back into those activities and get back to their life and make it as normal as they possibly can, as it was before the hospitalization occurred. Community support. Again, they have to be taught what those community resources are before they are discharged. They need to use people that were there during the hospitalization, for example, clergy people, to help with reintegration, because again, it helps build that self-confidence. You have to make sure that the appointments are made for them with whomever they need appointments for before they're discharged as well. You need to give them pamphlets, give them brochures about community support groups before they leave there. And you have to give them these things in writing. You tell them, but they have to have something concrete that reminds them and reiterates to them that they are not alone. And then when they get out there and they have that little bit of panic moment, or that little bit of almost crisis moment, that they have something to refer back to that brings them back to reality, so to speak, and lets them know that there is someone out there for them. And all of that has to be in place before you ever discharge them. And you have to have, like I said, it has to be written. They have to see it to be that reminder to them to know who to call, when to call, where to go, what to do, when to do it, and all of these things, because all they're going to worry about is what people are going to think about them. So all of this other stuff has to be taken care of before they leave for them. Okay, medication compliance. About 80 to 90% of of patients are given meds. And because nurses do not completely understand the biochemical aspects of medications, they see the drug treatment as an adjunct treatment rather than the primary treatment. Drug treatment is actually of primary importance to mental health patients. Compliance can be increased if the nurses understand how the medications work, when to recommend changes. They know how to teach patients to recognize when to regulate their own meds after professional consultation. Sometimes it's difficult for patients to remember to take the medications at different times. It is imperative that nurses examine the scheduling and consult the physician to make the most reasonable timetable for medication administration for these patients. Sometimes meds can be given in a once daily dose rather than several doses throughout the day. And then other medications, because of the metabolism, may not be taken this way. So the nurses have to be aware and have to be able to discuss this with the physician to make it the easiest that they can for the patients. Patients should learn to pair medications within a routine event. You know, if this medication is a once daily, pair it with breakfast. Make sure they eat breakfast. If it's, once in the evening, then make sure they pair it with dinner. If they always pick their child up at this time, or they always have to be on the bus at this time, whatever it is, pair it to some event that happens for them the same time every day so that it's a trigger for them. Drug treatment must be individualized for each patient. And they have to have their own boxes or dispensers, a daytime one, a nighttime one, whatever the case may be, to make it the easiest that it is for them. They can carry it in their purse or in their pocket. They can have checklists for the refrigerator or obvious places detailing the dosages of meds and the time that they need to be taken. If the patient is unreliable or if the patient is suicidal, you only give them enough meds for a few days with no refills so that they have to return for their appointments. Psych meds do have the potential for suicide as a complication or as an overdose potential. So you have to know what your patient is like and what their status is at that time. And these patients, then, like I said, you only give them a few doses at a time, so that they have to return, and you can check on them every few days. Then they should never be given enough meds to cause an overdose. Period. Um, Individual doses should go in paper packets or in plastic dispensers, and old packs must be returned to the nurse before they get more doses. That's again to ensure medication compliance. If they're not taking their medications, but they're telling you that they are, have them bring them back to you. Let you see that they at least don't have them there in the packages. Do not make accusations if the pack returns full, because if you do, the patients will learn to fix, quote unquote, their mistakes before they return, and the nurse will never be able to gauge compliance. So again, no accusations if they bring the packs back to you full. Sometimes it may be necessary for the nurse to make home visits or the therapist to make home visits to do a home assessment and uncover any problems that might escape outpatient settings. So that is something that has to be considered also, whether a home visit is necessary. Okay, so those are the most important things to remember about discharge teaching. I gave you a copy of a potential discharge summary and what it looks like and what has to be filled out on it. You have your lab guide to answer those questions, and this should help you answer some of those questions as well. The next 3 slides, I do believe, have some links if you would like to click onto them. Just different mental health issues. Some are about child mental health issues and about how to gauge if a child is suicidal. Also about promoting acceptance back into the society and different things. They are not anything necessary that you have to have, but they're just some good links to give you some additional information that might help you out. And that concludes our discharge teaching then for the mental health patient. And I hope this has been helpful.